Welcome to our podcast, Psychiatric Services from Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Nice to be here with you today on this beautiful Sunday afternoon. We are going to be talking about a more kind of complex economic-y article today. So I'm kind of excited about it because I wanted to go down that road. We haven't had one of these kind of articles in a while. The first author is Cameron Schilling, and you'll be introducing him. I did want to just go through the author list of the paper because it really is an amazing team of people, just to make sure that we appropriately credit the whole authorship team. So we've got Cameron Schilling, Matthew Eisenberg, Aline Kennedy Hendricks, Alyssa Bush, Hayden Huskamp, Elizabeth Stewart, Mark Meiselbach, and Colleen Berry. And this is really a heavy hitter team.
So we're lucky to have Cameron Schilling from the Center for Mental Health and Addiction Policy at the Johns Hopkins School of Public Health here to talk about his article, Effects of High-Deductible Health Plans on Enrollees with Mental Health Conditions with and Without Substance Use Disorders. Cameron, welcome to the podcast. Thanks for joining us.
Thanks, Josh. It's a pleasure to be here. Looking forward to our conversation today.
So as usual, I think we'll kick things off with just a question about how did you end up pursuing this area of research?
Yeah, I've been, I suppose, fairly interested in how healthcare payment, both paying of providers and the obligations from members and beneficiaries themselves, how that influences the health of individuals. I think about this in the context of what are insurers paying, what is the government paying, and what are individuals paying for their care. And I think these mechanisms are fairly interesting in how they influence health outcomes for individuals and the health and well-being of a lot of individuals. In particular, around high-deductible health plans, there's been a rise in recent years for the prevalence of these plans. And when it comes to mental health conditions, specifically in my own history, I found that I seek mental health care and other types of care more readily when there's less cost sharing, when I have to pay less out of pocket. And I think a lot of people may witness that as well. And so I thought this was an interesting direction to go for research.
It's also, in reading the paper and thinking about insurance, it always does feel like you can make a personal connection with it, right? Like for people who have health insurance, they're working with their deductibles or like, what is my premium and what's my copay?
Yeah, definitely. And I'd say that nobody's a perfect predictor of their healthcare use over the course of a year. And so the decisions that you're making when it's time for, whether it be open enrollment or your employer offering your health plan, it's what you're thinking about in that moment may not be, you may have completely different circumstances 9 months down the road. And your plan choices likely don't reflect that perfect prediction that we'd all like to make.
Yeah, and it's interesting because I think often the journal and the podcast focus more so on individuals who may be unemployed, who have severe mental illness, who may have social security, or more people with greater disadvantage. But every employed person who has insurance through their employer has to deal with this. And that includes a lot of people with very, very significant challenges, and really all of us.
This particular paper deals with what happens when people are offered a high deductible health plan. So let's start there. What is a high deductible health plan?
In the world of insurance, there is this concept of a deductible where it's money that you as an individual have to pay prior to your benefits kicking in from the insurer. And a high deductible health plan would be those insurance plans where the individual is exposed to a generally high component that they must pay prior to their health benefits kicking in from their insurer. So if you are seeking care, you're exposed to the total cost of that care up until you meet your deductible. And a lot of these high deductible plans are in the area of $1,000, even up to $6,000 for an individual that they must pay for the entire cost of their care prior to the insurer kicking in their share for paying for healthcare after that deductible is reached.
So just to be really concrete, the individual purchases insurance, and that insurance may come out of their paycheck or it's part of their benefit package. They pay that amount of money. And if they seek services, they have to pay the full amount of the deductible before the insurance pays any of the costs of their care. They pay for their insurance, and then they also pay for the amount of the deductible. Is that right?
Yeah, that's right. So they pay their premium, and that's the monthly part that might be coming out of their paycheck. And then when they do seek care, they have to pay the full amount to their healthcare provider or to the pharmacy for those prescription medications. And oftentimes, people with these plans will have what's called a health savings account or a health reimbursement account. And these accounts are generally used to offset some of the costs that are associated with these high deductibles. Those are bank accounts essentially that can be used for healthcare that the individual can contribute to, the employer can contribute to, but not all high deductible plans are paired with these accounts that are tax-free and can be used for healthcare. So about 60 to 70% of high deductible plans are paired with these special accounts for the financing of their healthcare, but there's definitely a large group that don't have access to these special savings accounts.
This paper is specifically looking at people with co-occurring behavioral mental health and substance use disorders and how the presence of a co-occurring disorder changes in the context of a high deductible plan. But let's before I get into that, how does having a high deductible change behavior? How might it change behavior in general? So let's say that I have to pay $2,000 out of pocket going to the doctor before my insurance kicked in. Like, what are sort of the things that people think about when they have that high deductible that they're facing?
Yeah, definitely. There's kind of two main directions where that could go. Somebody could increase the level of care that they would seek, or they could decrease the level of care that they would seek. And the mechanism for maybe an increase in care is if I'm at the beginning of the year, I select my high deductible health plan, and I know that I'm going to seek enough care this year that I'm going to exceed this deductible. And so if I'm exposed to $2,000 of cost sharing right up front in the first couple months of the year, I'm willing to pay that. And then I know that all the care after I exceed this deductible is going to be cheaper for me than it would be under maybe another plan that I have access to. And so then I might tend to actually increase the level of care that I seek because I know that I'll in the long run or over the course of a year, I'll be able to save money. The flip side of that coin is a decrease. And I think a lot of the literature around high deductible health plans points to a decrease in utilization associated with these plans. And that mechanism would be, okay, I'm exposed to, let's say, $2,000 this year of a deductible, and I'm not expecting to seek care this year. And now I have this issue that I'd like to see a healthcare provider for, and I can no longer, or sorry, not no longer, but I'm exposed to this high cost and maybe I can't afford it, or I'm just hesitant because I don't want to pay the full cost of care here.
How can anybody navigate this to really understand? Like, it seems like you need to have a PhD in healthcare economics to be able to choose like a healthcare plan.
Josh, I study this stuff and I still can't decide. Like I still have a really hard time trying to pick what what works for me. And I have friends that ask me, "Oh, you study this stuff, Cameron. Can you help me out here?" It's like, I can, but this is a really, really challenging thing for a lot of Americans, and I don't have great answers for you, friend, that is coming to me asking, and I don't know how to do it perfectly myself. So yeah, I'm completely agree there.
Well, let's talk a little bit about what does the literature say about how this plays out for people who have a mental health diagnosis when they're faced with a high deductible health plan. What do we know about that already?
So some of the literature has looked at bipolar disorder specifically, but the literature hasn't looked at the effect of high deductible health plans on a broad set of mental health conditions. What we learned from some research by one of our co-authors, Elisa Bush, is that high deductible health plans have fairly little impact on spending for overall outpatient visits for those with bipolar disorder, little change for medications, inpatient hospitalizations, and that type of treatment. Largely no change for those with bipolar disorder. The group that I'm affiliated with, we've looked at substance use disorder a little bit, and I found a decrease in the overall likelihood that somebody seeks treatment for substance use disorder in particular. And so a hypothesis that maybe we have is that these high deductibles tend to decrease the likelihood that somebody seeks treatment for these conditions, but maybe not the amount that they seek treatment after they begin their treatment.
Your response reminds me again of how complex this is, because you had several dimensions to your response. So there's this issue of pursuing treatment for the condition that you're interested in, right? And then there's for any condition, so seeking healthcare at all and seeking, say, care for substance use disorder. And then you have the whole issue, like you just said, differentiating the likelihood from pursuing care from the amount of care once care is pursued. So you have to kind of keep track of all these sort of outcomes, right, that you're trying to understand.
And definitely there's a prioritization as somebody is making these decisions. Say I have a heart condition and a severe mental illness, and if I have X dollars that I can contribute to healthcare this month, and I'm exposed to a high deductible and I have to pay the full amount, which am I going to choose? So there's definitely a component of trade-offs, even within maybe the comorbidities that an individual has, as well as kind of their totality of healthcare that they seek as well.
So let's get to the paper. You're looking at people who have mental health diagnoses, and you're also looking to see if people who also have a co-occurring substance use disorder respond differently to a high deductible health plan than people who just have a mental health disorder. Is that right?
Yeah, that's right. So we look at, in the claims and enrollment and data from health plans that we have, we look at everybody that has a mental health condition, and we kind of stratify that group based on whether they have a co-occurring substance use disorder or not. And we're interested in that because those two groups have slightly different treatment barriers for seeking mental health care, coupled with also seeking substance use disorder care and mental health care. Those with substance use disorders tend to have more severe mental illness, also tend to have more kind of physical comorbidities in addition to their mental health and substance use disorder conditions. So that's why we decided to stratify it in that way. And we're looking for what is the impact of a high deductible health plan on their healthcare utilization overall, both for their mental health and substance use disorder care, as well as all their healthcare broadly.
So who are these people? So who are the people who are in this sample? So just so we can really clarify the reference here.
Absolutely. These are individuals that all have employer-sponsored insurance. So this would be individuals that are employees themselves or family members of employees that are offered a health plan by their employer. And we look at two groups of employers. We look at our treatment group, if you will, the group of employers or the group of firms that we see not offering a high deductible health plan. And then we see a switch to starting to offer a high deductible health plan. And we compare the change in the level of utilization to those employers that never offer a high deductible health plan. So those are our two groups of employers that we look at, those that we see to begin offering a high deductible health plan, and we compare them to those that never offer a high deductible health plan. And then within those firms, we look at all of the enrollees that have a mental health condition and stratify them by the presence of a co-occurring substance use disorder.
Through that, then you get to the difference between people with and without co-occurring disorders and how they respond to the high deductible health plan.
We calculate a lot of different types of spending in the utilization that these enrollees have, and we look at the change over time from the employers that didn't offer a plan or a high deductible health plan to now offering a high deductible health plan. There's a difference there. And then we compare that change to what was happening over the same time period among these employers that did not offer a high deductible health plan. And so that's kind of the difference in differences, if you will, that economists and policymakers like to talk about often, where we have the difference of our treatment group and the difference of our comparison group, and we compare those differences to get our estimate.
I'm so happy that you described difference in differences. I have one more in the weeds question, and Josh, don't kill me. Okay.
Go.
I know. To our listeners, this is risky. Fortunately, Josh and I are not in the same room. Just to be clear, the people that we're talking about are not necessarily people who have taken or who have purchased the high deductible plan. Am I correct? They are just people to whom the high deductible plan has been offered. Is that correct?
Well, Lisa, I'm so happy that you brought that up, Josh. I don't know if you are, but I love that you brought that up.
Everybody's happy. I'm thrilled.
Yes, and that's so critical for our kind of non-experimental design that we have here, because as we talked about earlier, many individuals, some do not, some only have, the option to choose a high deductible health plan from their employer, but many individuals have the choice to choose a high deductible health plan. And so when we, thinking about this in the context of maybe a randomized control trial or other types of study designs, this is kind of an intent to treat analysis. And I'm on Zoom here and I'm using my air quotes, but that's exactly right. We're looking at the offer of this high deductible health plan. And so these enrollees that we're looking at may or may not be actually enrolled in these high deductible health plans. What we see in the data is about 40% of these enrollees are actually enrolled in the high deductible health plans, but 60% are not.
It's so important, again, getting into the methodological weeds because of the fact that if you just looked at the people with the high deductible plans, that would be a selected group, bias group. So if you're really into this stuff, read the paper. I mean, read the paper anyway, but it shows me how challenging it is. And so it seems like a simple question, right? But it's not so simple to answer the question. So that's, I respect this so much. So, okay, now I'm done with that part of my questioning. Now can we get to the results?
So what happened? What did you find about people who've been offered a high deductible health plan?
Well, Josh and Lisa, I could talk about methods all day. That's what I love too.
No.
Yeah. So what we find, and I'll talk about those enrollees that have both a mental health condition and a substance use disorder. First, we see a decrease in their total non-mental health and non-substance use disorder spending. So this is that non-behavioral healthcare component. We see a decrease there, and we see that decrease is driven by outpatient E&M type services. And in the literature, high deductible health plans, they do often decrease spending and utilization in these maybe less acute settings. So think about, your outpatient services, your medications, et cetera, but not so often emergency department use or inpatient hospitalizations. And if you think about that, if you need that care, that high acuity care, the cost is probably not going to stop you. If you have a broken arm, you're probably going to go to the emergency department, or if you're having an episode that needs care, you'll likely make that decision to go seek care. So getting back to our results, and then among this group with both a mental health condition and a co-occurring substance use disorder, we looked at their medication use and found that, or detected rather, decreases in spending on psychotropic medications, so the medications used to broadly treat their mental health conditions, but didn't see the same decrease in spending on medications to treat their substance use disorder. That was an interesting difference between the medications that individuals with these co-occurring conditions are using, and we see a decrease in the mental health medications, but not necessarily the substance use disorder medication.
What did you make of that and your other findings? How did you translate back into your hypotheses about the mechanisms of how people react to these plans?
I think I mentioned previously that those with bipolar disorder in prior literature have been found to not decrease their medication use for bipolar disorder. And we think of bipolar disorder as on the more severe side of mental illnesses that we look at in this paper. We look at mental health conditions quite broadly, and that reduction in spending on psychotropic medications, we're hypothesizing that maybe this is driven by spending on medications for less severe mental illnesses. So maybe things such as antidepressants or medications to treat other less severe mental illnesses. And that kind of fits in with the point I brought up around ED use, is if there are maybe greater consequences to foregoing care, then maybe you prioritize that care further and are willing to put up with this high deductible that you have.
I would just say that, that's a hypothesis, right? That's testable in terms of,
Absolutely.
What is the reason why in the one group of, one versus the other, there's a reduction in spending. And I think it's just so interesting because how we perceive and value and understand the potential benefits of all of these treatments is so unknown. Because of course we all know that there are people who have depression for whom, if we were just to make the case that it's antidepressants, which of course I know you're not saying that, you're talking about severity, but that where it's a life and death situation. And what really matters is how the person perceives it, right? Anyway, it just, you could go down a million rabbit holes with this, but it's just so important from a person-centered standpoint, I think, to understand it more deeply.
Absolutely. I think it's a needed area of further research, and I hope that we can understand this further. I'll also bring up, we did see a similar decline in medication use among those that have a mental health condition but don't have a substance use disorder. So we detected the same decline in spending, also same decline in spending on outpatient E&M services. But among this group of enrollees with mental health conditions without a substance use disorder, we actually detected an increase in spending on emergency department visits, which was kind of a surprise to us that I think warrants additional research. That is, are there health risks actually to high deductible health plans, and maybe the behavioral consequences that they cause related to declines in antidepressants or other types of medications and mental health care.
Yeah, and the study doesn't tell us that, but it does caution. It raises cautionary flags.
Yes. Absolutely another area for potential research, and hopefully we can understand it further.
So lots of directions for future research here, but it also just points back to some of the complexity we were talking about earlier for what seems like it could be this simple question that you're asking.
Yeah, definitely, Josh. And I think it's important to remember for the listeners today that we studied a offering of a high deductible health plan from an employer. And so whether or not the enrollees actually enrolled in these high deductible health plans is not really a part of what we looked at, but we actually looked at the employer decision to offer this high deductible health plan. And so when we think about a 4.8% reduction in spending on mental health care among enrollees with mental health conditions, this is likely driven by those enrollees that were actually enrolled in the high deductible health plan. And that's about 45% or so of the enrollees at these employers. If your listeners want to do a local average treatment effect calculation, they can definitely do that, but I won't bore them with that calculation. But then the other kind of main finding that we discussed today was around the reduction in spending on non-mental health care, and that's a 1.8% estimated reduction in spending on that non-mental health care. Listeners can draw those comparisons of those two estimates.
So just to follow up on that, I don't want to know about the local area treatment effect, but
somebody will, and they will call you.
No, I do actually want to know, but the point is, I think that the actual impact on the individuals who select the high deductible health plans may actually be much greater than the 4.8% and the 1.9%, because they're a subset of the population that's driving the finding. 5%, maybe that's not so bad. But actually, if it's like 30%, we're talking potentially some really substantial impact on health spending, which could have very substantial impact on health. And think about it, this could also differentially affect, people who may be employed and have employee health plans, but are poor and have very little marginal income and savings to deal with unexpected healthcare expenditures. And, it's a little scary.
That's right, Lisa. Very, very nicely said. And I think there's a lot of interesting work to be done to understand this and untangle this further.
Well, we're definitely looking forward to seeing the follow-up from you and your collaborators. So thank you so much for joining us. It was a real pleasure.
Thank you.
Thanks, Josh. Thanks, Lisa.
Yeah.
Likewise.
We invite you to visit our website, ps.psychiatryonline.org, to read the article we discussed in this episode, as well as other great research. We also welcome your feedback. Please email us at psjournal@psych.org. You can rate and review the podcast on iTunes, Stitcher, or wherever you listen. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you so much for listening. Talk to you next time.
The views and opinions expressed in this podcast are those of the individual speakers only and do not necessarily represent the views of the American Psychiatric Association. The content of this podcast is provided for general information purposes only and does not offer medical or any other type of professional advice. If you're having a medical emergency, please contact your local emergency response number.